Hello, friends, it's Medicine Simplified. Have you ever wondered why do some patients literally drown in their own lung fluid while others have the same condition, but the heart isn't even the problem? This is pulmonary edema, and in next few minutes we will understand it, and you will never confuse between cardiogenic versus non-cardiogenic again. So pulmonary edema is fluid in lungs. There's oxygen that cannot enter the blood, which causes the condition hypoxia. Now, there are only two main types, cardiogenic and non cardiogenic. Cardiogenic, as the name suggests, is related something to the heart, whereas non cardiogenic is not. Cardiogenic is a pressure problem, whereas non cardiogenic is a damage problem. Now, in cardiogenic, there is left heart which fails and the blood backs up. Now, because of this, the pressure would increase and the fluid will get pushed into the alveoli, pushed out basically. And therefore, there is low protein in the fluid. The clue over here is heart failure cells. Now, let's talk about non cardiogenic, which is a damage problem. Now, this could be caused because of pneumonia, smoke inhalation, aspiration, trauma, etc. Now, what happens here is basically the lung membrane is damaged and the fluid would leak out, and this would cause the protein to move into the fluid. Basically, it's exudate. And the most important example to remember in non-cardiogenic is ARDS. We are going to learn about this. I'm going to make a video on this too. The clue over here is severe hypoxia that doesn't even improve with oxygen. Now let's understand it with the medical terms. Cardiogenic is a hemodynamic issue. Non-cardiogenic is a microvascular injury because of that. Because there is inflammation. Okay, let's understand it. So, etiology is there is increased hydrostatic pressure, left heart failure, volume overload, mitral stenosis. There's decrease in oncotic pressure because the fluid has low protein. Now, pathogenesis, as I had explained, there's Starling forces, that is, the the pressure is built up, and because of that the fluid is pushed into the alveoli. Fluid crosses capillary into interstitium and alveolar flooding. The morphology to see over here is engorged alveolar capillaries, pale pink intra-alveolar transudate, heart failure cells that are hemosiderin-laden macrophages. Now, non-cardiogenic. As I already mentioned about the causes, let's focus on pathogenesis. So, because of inflammation, there is alveolar epithelial or endothelial injury. Now, there is exudate. Basically, the fluid has high protein, which leaks into interstitium. Now, this can progress to ARDS, a very important example to remember. Now, let's look at the clinical distinguishers. So, PCWP, which is pulmonary capillary wedge pressure. Now, this reflects the left heart failure. Here, it is less than 20, and therefore it gets characterized into non-cardiogenic and not cardiogenic. If it would be cardiogenic, it would be more than 20. Now, there is no increase in BNP, that is brain natriuretic problem. So there is no increase, therefore it's non-cardiogenic. Bilateral infiltrates without GVD. What does this mean? So this means bilateral infiltrates is basically when there is fluid in both the lungs. So in non-cardiogenic, we do see the bilateral infiltrates, but it is without the JVD, which is jugular venous distension, which is seen in cardiogenic. Hypoxia refractory to oxygen, which means there is hypoxia, but it does not improve with oxygen. So, this is just a short video, and I hope this helps a lot. If you like the video, please hit the like button, and I'll make a video next on ARDS, which is a very important topic as well. Thank you so much for your attention.